Okay, I think we'd like to start the next session. I'm Steve Nimer, and I'm representing the Myelodysplastic Syndrome Foundation. And I want to welcome everyone to our very first MDS Foundation EHA joint session. This is something that we hope will be an important component of our future meetings. We were able to give out some Lifetime Achievement Awards yesterday, and we hope to continue to innovate during this meeting. And I now have the opportunity to introduce my co-moderator, Antonio de Almeida from Portugal, who is the president of the EHA.
Thank you very much, Stephen. And a huge word of thanks to the MDS Foundation and this meeting for being so innovative. I must say, one of EHA's main vocations is to support physicians in their areas of interest. And so we have specific grants for researchers, we have support for educational activities, but the closer we are, the better. And this MDS community has been very innovative. Thanks to the MDS community, we now have big consortium grants for the whole hematology community. We now have joint symposia, not just with national societies, but also with scientific societies. So it's very gratifying, and hopefully this will be the first of many. So thank you very much for innovating for the whole community, not just for your meeting. And now, without any further ado, it's my pleasure to invite Kirsten Gronbaeck from Denmark, who's a well-known expert in CHIP and MDS, to talk about treatment of CHIP and CCUS for these patients. Thank you very much, Kirsten.
So thank you very much, and thank you very much for the organizers to invite me to talk at this symposium with my two favorite organizations in hematology. So today I'm going to talk about what we have learned, first of all, from epidemiological studies, what about the clinical trials in CHIP and CCUS, and then finally I'm going to focus on our own trial of the role of vitamin C in these patients. So stem cells once in a while get a mutation, and that mutation may give the cell a certain fitness so that it can expand and take over the bone marrow. Now, more than 90% of these mutations are in the 8 genes that you see here, and more than 80% of them are in the epigenetic regulators DNMT3A, TET2, and AXXL1. Now, this condition is much more common after the age of 60. However, if we use very sensitive methods, these mutations can be detected in virtually all of us. So there's an arbitrary cutoff of a variant allele frequency of 2%, after which we call it CHIP. Now, CHIP seeds the source for MDS and AML to develop, and this process is highly dependent on aging, but also the germline and genotoxic stress. So in this figure, I'm actually missing the patients that we get referred to us with long-lasting unexplained cytopenia or CCUS, and they often come to us up to 10 years before MDS and AML develop. So this really opens up an opportunity for early intervention. So what have we then learned from the epidemiological studies that have been conducted over the past 10 years? Well, we know now that the risk of progression from CHIP to a hematological malignancy is actually very low. There's also still debate about the role of CHIP in other age-related disorders like cardiovascular disease. And now 3 different scoring systems have been developed: the CHRS, the multi-parameter prediction of myeloid risk neoplasia, and the CCRS, which is a risk prediction in clonal cytopenia. The 2 first are highly based on the UK Biobank, which is young and healthy individuals, and the last one come mainly from secondary and tertiary institutions, with more than 35% being patients that previously had a different hematological cancer. So we were actually wondering, what about patients that are referred to us unselected with unexplained long-lasting cytopenia? Now in Denmark, we have a social healthcare system, meaning there's equal access to medical care, but also all our patients are primarily referred directly to the departments of hematology. So we had a chance to look into this. So the patients come with unexplained cytopenia. We look at the bone marrow and for chromosomal aberrations. They might have MDS, but if not, they have per definition idiopathic cytopenia of undetermined significance, or ICUS. And if they have a clonal mutation, then they have CCUS. And CCUS are actually the ones that come from CHIP. Now, CCUS are also those that really are at risk of progression to MDS and AML. So we looked into the overall survival of 682 patients with CCUS and low-risk MDS and stratified them according to their level of cytopenia. And we heard a lot about classifications today and stratification, but we took this very, very pragmatic approach. And what you can see here is that patients with CCUS with anemia and one additional cytopenia do almost as badly as the one with low-risk MDS. You can also see that when these patients come from the general population, the median age is actually similar to MDS, it's 74 years. We then looked into the risk of progression, and actually CCUS in this patient population rarely progress. So after 5 years, only 6% progresses. And that is to a higher risk disease defined as more than 5% blast in the bone marrow and 2% blast in the peripheral blood. So what about progression to a higher risk disease when we stratify by age? It's even worse when you look at the really old patients, which are quite a large amount of these patients. The risk of progression after 5 years is 3.8%, and 50% of the patients would have died from something else. It's less pronounced, of course, if you look at the little bit younger age. So who should we follow them, and how should we follow them? I think that all patients that get referred with long-lasting cytopenia deserve a full diagnostic workup. We need to identify high-risk CHIP and CCUS, and both high risk of progression and high risk of death. The prediction scores we have at the moment are good at identifying cases that progress, but they are not efficient in predicting survival in an elderly population. Now, I haven't been talking about this, but of course there are also structural aberrations at a clonal level or mosaic chromosomal aberrations. These are not included in the scoring systems, and neither are germline genetics, and maybe that could actually be helpful. We know that CCUS with anemia and one additional cytopenia should be followed by low-risk MDS, and very few CCUS patients will actually progress to a high-risk disease within 5 years. So symptoms might actually be the most important follow-up parameter, particularly in the elderly population. And beware of the comorbidities, they are the main causes of death. So what I haven't touched upon here are the context-dependent CHIP and CCUS, particularly those that are related to therapy. And I'll just shortly mention that. So Simon and Kirsten here looked into how clones behave under the pressure of chemotherapy, and we could see that DNA repair mutations really increase under the pressure of chemotherapy. But what they could also show was that patients with CHIP mutations in DNA repair genes after high-dose chemotherapy and autologous stem cell transplant have a very poor overall survival compared to other CHIP mutations and patients without CHIP. And they actually die from therapy-related myeloid neoplasms, but even more so from severe infections. And similar data have been shown for solid tumors by Kelly Bolton and many others later. Also, there's a new study from the Mayo Clinic here I think is very important, showing that in therapy-related CCUS, the risk of progression and death is actually much larger than in general CCUS patients. So, when does therapy-related CHIP and CCUS matter? Well, therapy-related CHIP mutations in DNA repair genes, so PPM1, DP53, and CHEK2, expand under the pressure of chemotherapy and are associated with a poor outcome. Treatment with radiation, platinum topoisomerase inhibitors, PARP inhibitors, and lenalidomide particularly select for clones with mutated DNA repair genes. Now, the amount of previous chemo is critical. And what about CAR-T? We now see a lot of therapy-related myeloid neoplasms after CAR-T, but is that really dependent on the amount of previous chemo, or is it CAR-T itself? Age about 60 is important. We know that combination of mutations and mosaic chromosomal aberrations are associated with poor outcome, and therapy-related CCUS have a poorer outcome than a regular CCUS. So what is the solution? I think in elderly patients that relapse, we should look for therapy-related CHIP and DNA repair mutations before we start any further chemotherapy. And maybe we should start clinical trials in this category as well. So this still leaves us with some open questions, because what about the deaths that are not related to myeloid cancer progression? Are they also related to the myeloid clones? Can we prevent or postpone this progression of death? And can we prevent or postpone some of the comorbidities or other causes of death that are not related to myeloid cancer progression? And how should we do that? Is it best done by targeting the factor that stimulate the clone itself, or downstream effectors of clone mutations? So I think a good place to start is at the CCUS level with these interception trials, because these patients are coming to us. But however, what should be required when we select this therapy? I think first of all, we have to be very cautious with genetic testing. All genetic testing should of course be based on informed consent. In addition, it's essential that we identify high-risk patients. We don't want to make 10% of the population above the age of 66. And the drugs that we use should actually be largely non-toxic without affecting the individual's quality of life. They might need to take this drug for the rest of their life. There are a lot of some ongoing clinical intervention trials in CCUS and low-risk MDS. Many of them, you see up here, are relatively small single-arm trials, but there is one double-blinded placebo-controlled phase 2 trial here from Uma, who is also here, on canakinumab, when this is based on data from a cardiological trial where canakinumab seemed to be efficient when TET2 is mutated. So this will be really interesting to see. We are working on 2 trials, a single-arm trial with metformin, and I so regret it's single-arm, and then I'm going to talk more about our vitamin C trial. So, what about vitamin C? Well, it was shown some years ago now that vitamin C is a cofactor for the TET enzymes in the conversion of 5-methylcytosine to 5-hydroxymethylcytosine. And the idea that vitamin C can be used in cancer prevention is not new. So this is from the local news in Pasadena in 1980, and the author is actually not Linus Pauling, but Peter Jones, that you can see up here in the corner. He is our collaborator. And if you don't know him, he was also the guy who discovered the hypomethylating effect of azacitidine. So this was almost at the same time. What Peter did was he added a chemical carcinogens to cell in culture, and you can guess which of these 2 dishes had the vitamin C. It's of course the one where there was no malignant outgrowth, the black dot here. So this is an outline of his experiment. What you can see, they treated the cells for 24 hours and then just left them. And briefly, you can see here that there is like a dose-dependent reduction in the outgrowth of clones. But most important, I think, is the one here at the bottom. If you only give vitamin C for half of the time until day 23, there's still no outgrowth, indicating there could be a preventive effect of vitamin C. So based on this and the news about TET2, we started looking into vitamin C in different studies. And one day, Peter sent me up to the ward to measure vitamin C in our patients, and that was really a shock to me, how low levels of vitamin C there was within those Danish inpatients. We did a pilot study, a very small randomized trial, and then we decided to actually go on with a trial in low-risk myeloid malignancies. So we designed this back in 2016, and we were very happy the year after this paper came out from Michael Akotopoulos, showing that gulo mice who do not produce their own vitamin C and are transplanted with TET2 FLT3 mutated cells, in those mice, all vitamin C could actually prevent the outgrowth of the myeloid clone. So we're not the only one who's been looking at vitamin C in CCUS, so this paper was published last year. Now, at that time, there was a long discussion whether we should use high-dose intravenous or all vitamin C, and they chose the high-dose regimen and only in TET2 mutated individuals, enrolled 10 patients and gave them high-dose intravenous vitamin C for 12 weeks, 3 times for 12 weeks. There was no clinical responses, but interestingly, they saw some hypermethylating at CPGs at enhancer sites that we know are associated with the 2 mutations. We took a different approach. We did an international multicenter double-blinded randomized phase 2 study, and it was placebo-controlled. We enrolled patients across 4 sites in Denmark and the US. and included a total of 109 patients. If patients were taking vitamin C, they had to go off any all vitamin C before we started the trial. And they also had to have a clone. We included both CCUS and low-risk myeloid malignancies. The patients were given all dose vitamin C 1,000 milligrams a day or placebo for 12 months and followed up to the end of trial. So remember, this was back in 2016, so we chose as a primary endpoint the change in variant allele frequency in CD34 positive cells. I would not have chosen that today. Now we know much more about how these clones behave. We had also a number of secondary endpoints, vitamin C concentration in peripheral blood, safety, overall survival, and also exploratory endpoints like cytokine concentrations and global and site-specific methylation. So at inclusion, these patients were also vitamin C deficient, though not to such a high extent, but more than half of them had some kind of vitamin C, vitamin C was inadequate, and more than half of those who had an adequate level were taking vitamin C supplementation, and remember, we took them off if they entered the trial. So this actually shows us that our patients adhered to the trial. So those in the placebo group stayed low, below the adequate level, while we were able to raise the level of vitamin C to the high end of the normal range in those who achieved vitamin C, meaning plasma saturation throughout the trial. Now, this study was part of Stine Mikkelsen's PhD. And so one late night before unblinding the two arms, Stine got this result, and you can imagine the fright she got, because obviously which ones were the vitamin C. Luckily to us, the vitamin C are the ones in the yellow, of course, and this, of course, was a surprise. It was not planned for looking into overall survival. It was a phase 2 study, and of course these data should be taken with caution. But I would say that ever since we've been trying to find out if there were some inherent differences between the two groups. So, first of all, yes, in the vitamin C group, they were a little bit younger. They were a little bit more male. And we could see that they had a little less cytopenias. On the other hand, when we went on to look at the prognostic scores, the IPSM score was lower in the placebo group, CPSS-small was lower in the placebo group, and there was a lower mutational burden in the placebo group. So we think it was actually quite balanced between the groups. We also did a multivariate analysis just to see if we could correct for some of these factors, and still vitamin C was an independent factor for survival. We then looked into disease-specific death, defined as death related to progression, bleeding, or infections. And you can see there was a lower hazard for disease-specific death in the vitamin C group compared to placebo. We also looked into the risk of progression. And again, there is a difference, but it's not significant. And if you remember the data I presented in the beginning, progression is very slow, actually, in these patients. We chose at the primary endpoint, I said, the change from baseline to end of trial in clone size, the cumulative change. There was a 20% increase in the vitamin C group and 31% in the placebo group. This is not significant. We also looked at the clonal dynamics, and interestingly, you can see that we see more contracting clones in the vitamin C group, but still, this also is not significant. Some years ago, we looked into the inflammatory load in CCUS and MDS and saw how that relates to survival. And you can see here that in the blue line that if you have a high inflammatory load, this is associated with a poor survival. You have to trust me that within these groups are high levels of IL-6, IL-10, and CXCL10, and low levels of RANTES. Because then we went to our patients in the clinical trial. We investigated 19 different cytokines, and these are the ones that were significantly different between vitamin C and placebo. And if you remember the ones I mentioned before, you can see that IL-10, IL-6, and IP-10 actually are lower in the vitamin C group, and RANTES are higher in the vitamin C group, so this actually aligns with a lower disease burden and a better survival in the vitamin C group. We looked at global methylation changes, both 5-MC and 5-hydroxymethylcytosine, and saw no differences between the groups. And then we did a pre-planned subgroup analysis on survival, stratified according to TET2 and IDH mutations because they would be dependent on vitamin C. And much to our surprise, we saw that the benefit of vitamin C seemed to be in those cases without TET2 and IDH mutations, or the most of the benefit. So we then looked into our patients, and many patients actually had 2 TET2 clones with a VAF around 50%. So we actually think that in those patients, there were no functional TET2 left. So we looked into methylation, also on site-specific methylation within this group, and what you can see here in cases with TET2 and IDH2 wild type, we see significant hypomethylation, and that was not seen consistently in the ones with TET2 and IDH mutant cases. So looking into which were the genes that got hypomethylated, well, this happened mainly at promoters and enhancers of genes that are involved in lineage commitment and immune function. So to conclude on this, we think that all vitamin C certainly showed the ability to raise the plasma vitamin C level to the high end of the normal range continuously throughout this trial. It was safe and well tolerated. The clonal growth rate did not change significantly, and the vitamin C significantly changed the cytokine profiles in a direction that aligns with better outcomes. All vitamin C was associated with a significant improvement in overall survival, although these data should be taken with caution. It's phase 2 still. The survival effect of vitamin C seemed to be in cases with wild-type TET2 and IDH2, indicating that TET2 is really the target of vitamin C. We could also see that vitamin C is associated with hypomethylation that occur at key regulatory genes involved in lineage commitment and immune function in those cases of wild-type TET2 and IDH2. And we think these data altogether deserve further investigation in a phase 3 study that is really powered for investigation of overall survival. But I think to end this talk, I think it's important to realize that we really need also in these patients to do randomized controlled trials in large enough patient populations. And this will be the case both in CHIP and CCUS and also in therapy-related CHIP and therapy-related CCUS. And hopefully we can do that with a clinical endpoint. So I would like to acknowledge all the patients and their families, and particularly Stine Ulrik Mikkelsen, who's been running the vitamin C trials together with Ali, Amalie, Anders, Astrid, Dicte, Jakob, and Simon, and all the others. Peter Jones for encouraging us to do these vitamin C studies, and Jens Lykkesfeld, our local vitamin C expert in Copenhagen. My collaborators who delivered patients and samples, and our funders, in particular, Van Andel Institute Stand Up to Cancer Epigenetics Dream Team. So thank you very much. Time.
And I think we're going to go and have both talks, and then we'll have time for discussion. And so it's my pleasure to introduce Dr. Michael Savona from Vanderbilt University in Nashville, Tennessee. He will talk about treatment of CHIP and CCUS.
Thank you very much, and good to follow Kirsten. I can hear all your stomachs collectively gurgling, so I'll try to make this quick. These are my disclosures. So today I'm going to talk about not one particular story, we have a few, but I knew Kirsten was going to talk about this interesting vitamin C story, so decided instead to think thematically and try to be provocative, talk about inflammation in general, and really start thinking more about not the molecular epidemiology of these clones in CCUS and in CHIP, but rather the mechanism and the context which they create inflammation. I want to talk about like our collective efforts to track clones and how they behave over time. Is that better? Yeah. When they'll be amenable to secondary and tertiary prevention, And then I want to talk about how we translate this to dangerous clones and finding ways to remove them, and tell you a little bit about some of the things that we've done. So I think, like, in a very simple way, we think about, you know, in inflammation, too much of the pro-inflammatory, and, you know, we get burnt. We have an autoimmune phenomenon, and too much of a permissive environment, and we have a clone that can grow. And most of us operate in a place where there's, you know, homeostasis of these pro and anti-inflammatory molecules. And for some reason, this can get off-kilter, and the teeter-totter can go higher in people who have CHIP, which we see clinically in things like RDW and so forth, that we know, or MCV, we know are labile in people who have CHIP. And as you've heard a lot at this meeting, there are a variety of growing new inflammatory factors. I wish I knew about ADP heptos before I made we wrote this paper, because I think, you know, the influence of the microbiome that Dr. Starzanowski talked about yesterday is an example of a whole, you know, war chest of ideas we're going to get on how this inflammatory milieu is caused specifically to lead to different clonal growth. So we know that inflammation leads to the rise of MDS, and in our field, we tend to think about this one way. You know, people have an insult. They develop CHIP, and then CHIP is this pro-inflammatory, you know, the second line here is clonal inflammaging. But, you know, there's a whole field of aging scientists who think about SASPs, which are the same pro-inflammatory cytokines that we're talking about after the accumulation of a CHIP clone, but they think about this in the setting of aging, and how with normal aging there's an increase of sterile inflammation, of adipogenesis, of increased reactive oxygen species, and ultimately an environment that leads to the generation of new clones. And VEXUS is really this kind of cool model of, like, both of these things in this feed-forward system. So I don't, you know how much it matters, but I think right now, but I think thinking about context is really, really important with respect to CHIP and inflammation. And we know that inflammation means lots of different things. When we did our work on the World Trade Center dust, that, you know, what these gentlemen, they're larger gentlemen, breathed in from that particulate matter was different, caused a different kind of inflammation that led to a different set of clones than, you know, the black carbon that Dr. Shastri talked about yesterday that was higher in the Bronx than other areas. And as was just mentioned a moment ago, we have these ways to track clones. You know, we've developed these scoring systems, and they ascribe risk in different contexts fairly well. I use them in my CHIP clinic. I started CHIP clinic in 2018, so I've had some longitudinal study, and this has been great, because a lot of times I just stare at people year after year and say, well, you look good, see you next year. And I'm starting to get a better sense of how maybe I should turn up or turn down the dial based on some of the work that's done. But the truth is, they're still not good enough. The new models assign risk, but they don't account for variant-specific risk. There's a hint of this in the MN Predict, where DNMT3A risk is driven in AML specifically by 882, that specific residue. But as we've shown, and I've presented this a few times, so I'm not going to go into the data, but both on the epidemiologic and on the molecular level, and this is terrifying, but it's not just 882. It's the specific codon change that increases the inflammation and the risk. This is from UK Biobank, 1,400 patients, the biggest source of RNA2 CNH patients that we have. And in that data source, basically all the myeloid malignancy risk is driven from that RA2H clone and not from other DNMT3A clones, which means if you're discounting DNMT3A as low risk, you might be throwing out a particularly high risk RA2H clone you know, by using the CHRS, which is a great model, but it doesn't account for this. Similarly, we showed that RA2 not H, RA2H not C rather, accounts for the increased risk of cardiovascular disease. It's not quite significant in coronary artery disease, but it's trending that way simply because of numbers, and certainly has the impact on all-cause mortality. It's been mentioned, I think, in passing a few times over the course of this meeting. There's two really interesting papers that were just published a week or two ago in Nature, one from George Valdesalo's lab and one from Jennifer Trowbridge, looking not at H or C, but at least at the specific residue 882. And what they discovered is 882 is oxphos-dependent. Oxphos-dependent CH, which is associated with inflammation. And interestingly, with this weak oxphos inhibitor, they're showing information of how they can reduce the inflammation by shutting down the energy source for that cell. So what they did is look in the UK Biobank again and controlling for the principal components of ancestry, age match, diabetes, everything. They just basically looked at people who got metformin versus people who didn't get metformin, and 10 years later see what the rates of CHIP were. And surprisingly, the metformin patients had less DNMT3A, which was driven entirely by this R882 clone. And I won't get into the details, but suffice it to say this picture kind of says it all. I don't know if you can, yeah. This is a methylome, and if you don't do bisulfate sequencing or methylation sequencing, DNMT3A is a DNA methyltransferase that works on the entire genome. So normally, this is vehicle here. In the case of a normal mouse, metformin really doesn't have an effect on the methylation. You can see in this 878 heterozygous model, which is the murine homolog for R882, you can see aberrant methylation, even if you don't know which genes these are, just to kind of see the color changes. And interestingly, the mice treated with the metformin kind of go back to this, this same kind of methylome that you see in vehicle or the normal mouse. So, I mean, for this part, I just want to get the point across that not all clones are created equal, and we need to be thoughtful about this in our risk assessment. Clones induce inflammation, but inflammation may cause clones. It's very heterogeneous, and it's not quite a dirty word yet, but we're going to get to the point where saying inflammation is not enough. We're going to have to contextualize this better. And risk models are really a lot of work. I participated in one of them. Zoe Shear did a great job. And Lachelle Weeks did a fantastic job, as did the group in Cambridge. And I use them in my CHIP clinic all the time. But they're ready to be iterated, and they constantly will be as the science develops. So the next thing I want to talk about is our work on tracking clones and trying to learn their behavior, how they behave over time, to try to give a little bit more context for these questions. So I started this repository called CHIVE, which you may have heard of. It's clonal hematopoiesis and inflammation of the vasculature. I also discovered it's a very racy website, if you want to check it out after my talk. I didn't mean that when I named it CHIVE, but anyhow, shortly after I started CHIVE, I recruited this guy, Alex Bick, who's really just been a transformative human genetics faculty. He's been there 4 years. He's already tenured and director of the human genetics division, and he's now running the clonal hematopoiesis and inflammation of the vascular repository, and we're doing some really great things with this. This is Ashwin Kishtagari, who's a junior faculty who's looking at underrepresented minorities in this repository. And the special thing about this, and as far as I know, this is the world's largest sequentially sequenced group of patients over many years. So we've had this now for 7-8 years, and have multiple, up to 12 to 15 different samples from patients over that time. And we have a rubric by which we follow them. The patients who can be enrolled in the study either they have a clone, over 18 and they have a clone, or they're over 18 and have risk for CHIP, or over 40. So what that means is we had very loose criteria, and we're able to track people who had pre-CHIP, CHIP, CCUS, MDS, and AML, and indeed we have a cohort of those patients that's growing by the day. And my hope is to kind of start looking at germline context, not germline disorders necessarily, but germline context. What are the at-risk genomes? And this is an AI question that hopefully we'll be talking about in a meeting 2 years from now in Leipzig, or 4 years from now, wherever that goes. And people say, well, how are you doing the genotyping? Well, this was an important priority to do this work, was finding a way to do this cheaper. And we developed this Twist Bioscience hybrid custom capture assay, which basically covers 95% of the loci that are in what we classically call CHIP, the genes that are listed there. At 500x, so it's deep, we see small variants, and we can do it for about $8. So that really changes the game. You know, when I started this, it was $156 a sample, and you could only do so much sequencing, right? So if you can do this for, you know, less than $10 a sample, then you start to have the capacity to look at large swaths of patients, and in fact, we've done 100,000 now for outside institutions. I won't say anything else about it except that Alex's group has developed a chive methyl seq, which is actually pretty cool too, because it allows us to do methylation sequencing at a really low cost. So people interested in DNMT3 or TET2 biology, send me an email. I'll be happy to hook you up. So we published this a couple of years ago, and just to give you a flavor, I mean, there's two things, right? So when we look at UK Biobank or any of these big data banks, it's all retrospective. And they're usually whole exome or whole genome sequencing at not 500x, right? They're 30x or whatever the depth is. So, you know, there's some postulation that we might be underestimating CHIP by quite a bit because we're not seeing small clones and because the control arm is littered with disease. It's an interesting thought. I don't know how true it is, but looking prospectively with the deep sequencing capability gives us an idea to see if we're matching up. And without going through the details on this upset plot, you can just read that it's the same kind of genes for the most part in the same kind of epidemiology, molecular epidemiology that we see from the respective cohorts. We also, this was in 2023 when we submitted this, so there's quite a few more now, but at the time we had 6 patients who had entered this trial with CHIP or not CHIP, and then it progressed onto MDS or AML. And consistent with the things that we talk about, high-risk mutants, co-mutations, and high VAFs were consistent in all of these transformations, except one guy who had a TET2 frameshift mutation at 2% who turned out to have a germline predisposition syndrome. Okay, let's talk about what I was actually asked to talk about, which is treatment. Aditi Shastri presented at the IWG PM meeting earlier in the week, and for those not there, Aditi was really a leader in this project and trying to understand, at least put on paper, how do we actually start doing clinical trials in clonal hematopoiesis. And as Kirsten alluded to several times, although she had the benefit of doing a vitamin C trial, and the agencies don't care so much about giving vitamin C, a water-soluble vitamin, some of the things we're talking about using, like canakinumab, are not necessarily that safe. So the bar has got to be a little bit different. So what we did in this paper was try to understand how to define, or at least start the conversation around how to define objectives for these kinds of interventions. And this is the reference if you want to see it. I'm not going to spend a lot of time on it. There's really a negotiation of TRIP trial endpoints that really requires us as hematologists to think differently. We got to kind of think more like cardiologists who are giving someone a relatively benign drug, because you have to be if you've given it to someone who doesn't have disease, but they have a condition. But doing it across massive groups of people and then working with the regulatory authorities to find surrogate endpoints. And that's something that I've been involved with in the IWG, MDS, MPN, IWG, where we're very frustrated with the endpoints with CMML and related MDS MPNs, but we're going to have to tackle this in clonal hematopoiesis as well. And this is not something that we collectively as a group know really how to do, so we're going to lean on the cardiologists. So I showed this a minute ago. There's a million new inflammatory targets, and ADP heptos isn't on here, but I love that story so much, and I think attacking the microbiome is definitely going to be a place to go. You heard a great story about vitamin C. So that, the more benign or benignish type things we can do to people that don't have a disease, the better. But there is also, the use of things like, canakinumab, ivosidenib. And this was, when we published this paper, this was all that was on clinicaltrials.gov, and includes a lot of things that I've mentioned already enrolling, and this has expanded considerably since. Just to make the point, the mutation type and the kind of intervention is going to change your eligibility criteria, right? So if you're giving someone vitamin C, the agency, the EMA and the FDA they're not going to be too particular, but if you're giving someone canakinumab, you better show that you're treating someone who has a really high risk of developing a life-threatening disease like MDS or AML. So, the requirements to enter on study are such. I once gave some very bad advice to Uma, so just go after the TET2 patients after the Cantos study, because that seemed to make sense. But after seeing Kirsten's data, I'm not so sure that's such a good idea. So remaining open at this point is important. As was mentioned, there are already metformin, statin, and oral vitamin C studies that are ongoing, which are fairly permissive entry criteria. I just want to draw attention to one study before I tell a final story of something that we're doing at my place. This is a study by Kelly Bolton. Kelly, I don't think Kelly is here at this meeting. I haven't seen her. But she is a really bright genetic epidemiologist, hematologist, who is young faculty at WashU. And she did some great work with the IMPACT database that's kept at MSK Cancer Center, looking at all the chip that is generated from patients who receive cancer, and maybe that's what biased her towards IDH1, this fairly rare mutant in non-disease in CHIP or CCUS. But she realized it'd be difficult to do a study at one site, and she engineered what's called the PIM study, Preventing IDH Mutant Myeloid Neoplasms, where I think she's enrolled like 15, 20 patients already, and it's really a feat in how we need to be thinking about designing new clinical trials for people who can't necessarily make it into the major medical center. And I encourage you to reach out to Kelly, and because it's been, I think, a real move forward. Okay, so I had a really bright MD PhD, and he graduated this past week, and I'm going through a little bit of a depression because he will no longer be in the lab, but he's on to do his PSTP and become a hematopathologist. He had a great idea of designing these guide RNAs and using high-fidelity Cas9 without any kind of template cassette. And basically taking advantage of what's called intrallelic gene conversion. This has been used before, but nobody's really done it to remove single nucleotide variants. So we called it clonal reversion because that sounded cool. But basically what you're doing is you're someone who's got 50% or less of a mutant, so they have to have one good allele. The idea would be to go in and use Cas9 to cut at the guide RNA's directed site, specifically where that mutant is, that one residue. And then replace it through HDR to the normal template. So he made these very specific guides for a variety of different mutants, which we first tested in cell lines in this scrambled control. And you can see in the Sanger sequencing, the red peak here goes down with the guide RNA. And we use plus or minus HTA enhancer just to limit indels. This was true across a variety of different mutants, different cell lines, and with or without the HDR enhancer, which didn't really change the efficiency. It just improved the reduction of indels, which I guess is improvement of efficiency. So I'll give you an example of some of the ways I'm thinking about this, and what we're doing is this was a K562 transplant. So K562 is this CML gone bad with lots of different secondary mutations, and it has the ASXL1 Y591X truncation mutation, and he directed toward this mutation in cells prior to transplant, and the mice that were transplanted with the corrected alleles had a longer life. So this is just, and we had some trouble publishing this because people wanted to say, well, did you cure your leukemia? And really, it's just a lab tool right now. But the idea is, if you could direct that guide RNA to that specific mutation of interest, and you could reduce it by 20, 30, 40%, and do that repeatedly for different genes, in this case, can you actually make the cell line susceptible to imatinib again? So philosophically, we're thinking about leukemia and MDS about curing disease and eliminating the clone. Maybe in CHIP, it's not about eliminating clone. Maybe it's reducing the clone so there's less inflammation and letting the native habitat kind of give them a little bit of a push. Okay, so, I've talked to you today a little bit about the terrifying prospect of a single codon directing different risk. I talked to you about the work that came out of Cambridge and out of Jennifer Trowbridge's lab showing that, at least the 882 mutant has a dependent on OXPHOS, which you can inhibit not with a really strong OXPHOS inhibitor, but with a mild OXPHOS inhibitor that's in the clinic and safe. talk to you a little bit about Chive. Please reach out if you're interested in collaborating. This is something we'd like to grow. And about all the different places we can go in the inflammatory milieu and CHIP, and some of the gene therapy ideas that we did. I'll just end and say that, you know, I held this annual meeting on somatic disease, and this is my backyard, in 2022. And in Nashville, you can hire local musicians who just want to be paid in bourbon. The problem is you got to wait till after the show to give them the bourbon. I learned that lesson. But it was a really good meeting, and you know, pharma dollars have dried up to support this kind of thing, so it's really hard to get sponsorship. But we did have the scientific symposium last year, and Irene Gobriel and George Vassialou and others have been able to be successful in promoting the IBC meeting, which covers, at least as a part of it, clonal hematopoiesis. So I encourage you to become engaged in that community. It's been a lot of fun. So thanks a lot. This is who I have to thank, very many. I won't read them off, but most importantly, my funders and the patients and their families who we're trying to help. Thank you.
Okay. Kirsten, if you come on up, and many questions. Why don't we start right in it?
Sarah from Brazil. I'd like to ask to Dr. Gronbaeck if you check the vitamin C intracellular, and also if you check another cytokines. And third question, the last question. Did you check the transformation of hydromethylcytosine to methylcytosine? Okay, thank you.
Yeah. So I think the first question, yes, we did check vitamin C intercellular. It was, and also in CD34 positive cells, and we needed that high dose for, you know, to get it saturated. So we have done that, yes. And you had several other questions, but I think I think we answered most of them. Yep.
Thank you both for great presentations. I have a question or maybe a comment. I like your presentation, Dr. Gronbaeck, about the chips in treating lymphoma and autologous stem cell transplant. But I was wondering, both of you, what do you think about these data about using myeloid chips in lymphoproliferative disorders like in CLL? And is it time that for a specific group of these patients, maybe we can use chip-targeted agents? Because we know that if we use venetoclax, BTK inhibitors, some of these patients have higher risk for more comorbidities. Some of patients will transform and have Richter transformation. And do you think that maybe for a specific group of patients, if we analyze chips in these patients, we can change the treatment, especially if we know that SF3B1 positive BCLL has higher incidence of atrial fibrillation, and maybe that would be the group of patients where we won't use BTK like ibrutinib, or venetoclax limited treatment and the risk of Richter according to chips like DNMT3A or ASXL1. Thank you.
So I think the question is whether we want to use some of these myeloid treatments in the lymphoma patients to remove their chip clone. Is that correct?
Well, no.
No.
I think that we can be chip-guided people in lymphoproliferative disorders. So if you know the basics of chip for CLL patient, maybe we can choose better treatment for that group. Because in all oncologies, we are moving from chemo treatment, and we are now more focused on targeted agents, monoclonal antibodies. What about that group of population? How is chip has anything to do with results of these treatments?
So I mean, we can talk about this over a 7-course meal, but I think the short answer is that there is lymphoid chip, usually in MCAs. So targeting MCAs might be more beneficial, and we're not there yet that I know of.
No.
Okay, thank you for excellent talks. Kirsten, the vitamin C data is very intriguing. Do you have information about the causes of death?
Yeah, it was in one of the slides, but went a little bit fast. I mean, the causes of death in the placebo group, there are only 3 cases that actually progress. Most of them die from infections, pulmonary infections and bleeding. We think it could be associated to vitamin C function when you think about collagen, when you think about improving immune system and so forth. But obviously, I mean, the numbers are not that big. And we are actually planning to do a phase 3 trial. And talking about new trial designs, we're going to use the Danish registries to identify these patients and contact them and then follow them really via the registry. So we'll get like 400 or 500 patients in the trial.
May I ask another small question? So, were you able to have bone marrows of these individuals in the trial?
Oh, yeah.
And then did you also in vitro treat them, do quality assays with high-dose vitamin C or in vitro assays?
We did not do the in vitro assays yet, but we have all the cells in the bone marrow we sampled at 3 different time points, bone marrow, but we're actually more looking into what we think is more intriguing now, is whether, first of all, in some cases, are the immune cells actually part of the clone? What does that mean, and how does vitamin C affect the epigenetic profile in different cell types? Because it looks like it's something going on, maybe more at a differentiated stage, and maybe also on the lymphoid side, actually. So, yeah.
Thank you, Mr. Babul Jha from Cleveland Clinic in US. When these high-profile papers were coming on vitamin C, so we have been struggling same time with our paper, which a part of the data you confirmed, and we published it later on a very low-profile journal in Nature Communication Biology. Now, what we found is exactly what your clinical trials suggest, and that paper hasn't been studied well, is that the TET2 wild-type patients responded well. And we did a lot of in vitro experiment, including the mouse model. And in the mouse model, which was TET2 wild-type gulo-deficient, they responded way better than either heterozygous or the homodeletion of TET2. And we have been arguing that the TET2 has a context dependence. And we have done a lot of elegant structural analysis why it is happening so. And because of the catalytic domain has the lysine, which remains acetylated even in a non-mutant TET2 in myeloid malignancies. And there's a lot of story around that. We published 3 or 4 papers just proving our hypothesis. Now, I have a quick question is that, and then we did, from last questions, we did these in vitro vitamin C treatment of TET2 mutant and wild-type patients in all kind of assays, and we found the TET2 wild-type always responded better against vitamin C. And we have shown that why it is so. The whole mechanism we have published in these 3 or 4 papers we published. That's the comment I had made. And I had a quick question about what was the initial basis for selecting vitamin C in a TET2 mutant cases that I still don't understand.
Well,
and what was the question asked?
Remember, this is years ago, right, that we designed the trial. And we have actually also done, there's a PNAS paper that is there where we could actually see that there was a dose-dependent function of vitamin C also on methylation changes. But we actually thought we could rescue based on, residual TET1 and TET3 actually. And so this was the whole idea from the beginning. But in the end, when we saw the data, we said, of course, I mean, this is the way it is. And this is not enough. It can't compensate. So for TET2 loss. We
know that. And we did a very careful analysis of the EC50 for vitamin C. It's around 10 micromolar, which is even the patient who has very low level of vitamin C, intracellular levels of vitamin C remains pretty high. Yeah. And that's more than enough to activate TET axis. And this is why your data suggests, including ours, that we don't see any difference in hypermethylation or hypomethylation as a result of vitamin C treatment in those patients. The TET2 wild type is the one which shows the most. Yeah, exactly. But also hypomethylation in type 2 wild type. Yeah. Thank you.
Yep.
So I also have a question for you, Kirsten. Very nice results. So 5-HMC is probably a good measure of the activity of your TET proteins in a cell in the demethylation process. Have you been able to look at the 5-HMC levels in the non-TET2 mutated and the non-IDH mutated cases? And if you stratify then for activity, do you see a difference in those?
We try to do that. We don't see a difference, no. No,
Okay, so that's
actually, so not on, you mean on the global level, right?
Yeah.
But we didn't see that. No, we were hoping, but no.
5-MC is probably more difficult because there's so many areas. Methylated 5-HMC is more specific. But
Yeah, but the thing is, these patients are treated over a whole year, and I think with HMC it's very futile. I mean, it goes away again quickly. Yeah.
Okay.
A quick question to Dr. Savona. So when you use your CHIVE-seq and GS panel to analyze the samples serially, do you see generally a steady, slow increase of the VAF, or is it fluctuating? Is it like jumping back and forth? And the second question is the clonal threshold for the metyl-seq analysis, the CHIVE metyl-seq. What's the clonal threshold needed to see relevant changes?
Yeah, it's so the second question I don't actually. I'll find out and let you know, Marcin. Thanks. I don't remember. It's very sensitive. The first question, we have a paper in that's being put together about this point, and it's actually mutation specific, where some mutations, tend to do nothing and then shoot up and occur with other mutations at the time of disease or progression of disease, and other mutations tend to move fairly predictably per pacer, which we use to predict, how those mutations grow.
Thank you.
Great. I think we're about to wrap up. I wanted to make a comment, and maybe you'd like to chat. I think one thing that we sometimes don't spend enough time talking about is actually biological assays. We look at blood counts and we look at the genetics. So Michael, I think you're serially analyzing patients, which is probably going to provide itself some really important information. And the second part of that is sort of when we look at vitamin C or we look at cytokines, do we really know what we're supposed to be monitoring? Maybe it is ADP hexose, and maybe it's some specific cytokine, or maybe it's these dangerous clone. It's not the size of the non-dangerous clone changing, but the dangerous one. And I'm just wondering about how often we serially monitor the patients, and also, of course, understand what people are dying from. With MDS, we used to talk all the time, either die of bone marrow failure or you die of leukemia. Now, you can die of a heart attack, of course, and many, many, many other things, infection. Why are your patients dying of infection? Is this something to do with the immune system rather than the myeloid compartment? So I'm just wondering, how do you think we can introduce the idea of changes over time?
Yeah, thanks, Steve. I really think that that's a critical question and something we're trying to address with sequential sequencing, because the body is not static, right? I mean, there are 11 billion cells produced in the immune system every day. So it's arrogant, frankly, to think that we're going to measure IL-6 at one point in time and actually make a real statement about this. And I would encourage folks, the young people who are studying bioinformatics and AI. This is an AI type question, right? It's not one or two cytokines. It's I'm old enough to have used a synthesizer, so like this, it's like a synthesizer. Getting the right motif is actually specific for mutations is going to be key to know. We can't calculate that. That's an AI type problem. As far as when to look, in CHIVE, we look at what we call higher risk CHIP. We look at them every 6 months. But to get this kind of enrollment and really speed of enrollment in lots of patients is important. I mean, we make it so when they're coming into the doctor. So we don't have a specific blood draw in CHIVE unless they're getting blood drawn anyway. But in CHIP clinic, I see people with high-risk CHIP every 6 months. So we're guaranteed to get blood every 6 months. If they have low risk, it's once a year. This is iterative. I mean, we all have to work as a community and figure out, does that really make sense? Should we alter that in some cases? Because I'm sure we're missing some. We're probably scaring some people and over-medicalizing them when they really don't need to come in at all. And hopefully the biology tells us more about this.
Kirsten?
Well, I was just say that I think it was very important. In our trial, we measured at several time points. And beginning of trial, before we even started, and end of trial. And when I'm talking about cytokines, when I'm talking about methylation, when I'm talking about anything, it's the difference between baseline and end of trial we're talking about. Because at least there, I think we see something, and we also show that you have a constant level of vitamin C in those that get vitamin C throughout the trial. We measured 5 times very meticulously. So I think this is something we should do also when we do make these trials. We should really follow the patients very carefully with our measurements. So I think that's what we can do for now.
Great. So I think we have to wrap up, but thank you very much. This was a great session, very innovative. And thank the audience and especially the MDS Foundation for this great initiative of the Joint Symposium. Thank you.
And EHA.